Does that look all right to everybody? I'm seeing some nods. So thank you very much again for allowing me to present today. I do have a disclosure, as was mentioned, I'm a co-inventor on the Wellbeing Index and its derivatives, which is owned by Mayo Clinic and licensed to MedEd Solutions. So today, what I really like for us to do is take a journey together to really get an understanding of what is the prevalence of burnout in healthcare workers. What do we know about some of the potential contributors? And really be able to learn the so what story. And by that, I mean, what are some of the consequences when healthcare workers are experiencing burnout? And then importantly, move forward with what could be strategies for us to mitigate the risk of burnout among healthcare workers, thinking at it really through the lens of shared responsibility. There's things the individual person can do. There are things that can be done at the work unit level and sort of beyond, which I will mention. You are all acutely aware of the data around mental health of U.S. workers and others, with data from the CDC showing that anxiety, depressive symptoms, suicidal ideation really have increased by staggering folds. And this was relatively new into the pandemic, but it has really remained elevated. And of course, U.S. healthcare workers are not somehow immune to that stress and may indeed have some different types of stressors or additional stressors. So there's been meta-analysis pulled together, which has really shown that every time there's kind of an emerging virus, whether that's SARS or Ebola or COVID-19, that it takes a toll on the frontline healthcare worker, with them being really at higher odds of developing acute as well as post-traumatic stress disorder and other forms of psychological distress. And the younger healthcare worker, the healthcare worker who's younger in their career, earlier in their career, are at higher risk, as are those who are parents of young children, healthcare workers who have infected family members or themselves experience quarantine, and healthcare workers with little support at higher risk for having psychological impacts from working on the front line of emerging viral outbreaks. Now, one thing that we have to remember is that although there's a lot of news in the press about the impact of COVID-19 on the well-being of the workforce in healthcare, the impact of COVID-19 on the healthcare has actually been very heterogeneous. So for the frontline workers, the workload has been very high for many. Some have had to work without adequate protective equipment. Some have had to make really difficult decisions about allocation of resources, which is called moral distress. But there are other healthcare workers, such as myself, I'm a primary care physician, who had to switch very rapidly to telehealth, right? So the stressors were different, figuring out how to deliver new models of care. And then there were other healthcare workers who frankly had very little to do, particularly around when elective surgeries were all halted, and the resulting furloughs and the resulting financial strain on some healthcare workers was a very different type of stress. Before the pandemic, we consistently saw very high prevalence of burnout as well as depressive symptoms in our healthcare workers. Doesn't matter if you will look at physicians, physician assistants, nurse practitioners, nurses, pharmacists, residents, medical students. Very little data in veterinarians, actually, and little data as well in dentists. But consistently, you see very high prevalence of burnout. And the physicians, at least who work more hours, are at higher risk, as are those who are younger. There's some data around women physicians may be at higher risk, but as I'll explain later, once you control for other things within the work environment, that gender-based difference actually goes away. Physicians who are paid entirely based on billing are at higher risk for burnout, as are those in private practice relative to academic medicine. And then there's big differences in the prevalence of burnout by specialty. So what you can see here on the slide is a big difference in the prevalence of burnout among physicians, with emergency medicine family docs consistently having higher odds of burnout relative to other physicians, whereas pathologists and physicians in Prev Med occupational medicine consistently at lower risk for burnout, even after you control for a variety of other factors. And when we look at other healthcare workers, we do see high prevalence of burnout, though somewhat lower than in large national cohorts of physicians. Many of the same risk factors with working many hours, working in the emergency department, increasing the risk among other healthcare professionals with respect to burnout. But it sort of begs the question, right? Doesn't everybody get burnt out? Is it really just something that happens to healthcare workers? What about, other people in the general population? Doesn't it just reflect our sort of 24/7 work culture? And since 2011, we have done big national studies in collaboration with the AMA, looking at, what is the prevalence of burnout in physicians? What is it in a representative sample of US workers? And as you can see from the figure there, physicians consistently had higher prevalence of burnout. Now, the good news is that there's data suggesting, our data here, that burnout is actually decreasing in its prevalence since there's been a lot of attention placed on it at a national and many organizations since 2014. Many are surprised that the level of burnout, overall in aggregate was lower in 2020. Now, this was 6 to 9 months into the pandemic. And an important thing to remember is that meaning, value, and purpose in work is an incredibly strong buffer against work stress. So in many ways, it can make sense to see that the burnout rate goes down. But a nuanced thing, though, is, of course, that the prevalence of burnout in our study did not go down in the physicians who really are working the front lines of care for COVID. So your emergency medicine physicians, your critical care, adult hospital medicine doctors, infectious disease doctors, we did not see the prevalence of burnout lower in those cohorts. And 6 to 9 months into the pandemic, about half of physicians had cared directly for a patient with COVID. About a third had delivered care without adequate PPE, and nearly 40% had experienced adverse economic consequences due to COVID. And having these sorts of experience increased the likelihood that the physician was experiencing burnout. And when we looked at this on multivariate analysis, controlling for other factors such as age, work hours, specialty, practice setting, et cetera, we saw that physicians who had provided care without adequate personal protective equipment and who had had adverse economic consequences from COVID were at higher risk for burnout relative to other physicians. So there's a high prevalence of burnout in healthcare workers. Why does it matter? Why should we talk about it? Why should we try to act on that? Well, there's many reasons. I've just picked a few to share with you today. One is really about professionalism. So we have done big national studies in both nurses as well as physicians that shows that burnout is an independent predictor of suboptimal professionalism. So this includes things like really having not ideal attitudes about how to practice cost-conscious medicine, which then drives up healthcare cost. Self-reported unprofessional behaviors are more common in healthcare workers who have burnout. And there's also a lower sense about accountability, sort of with respect to self-regulation. So physicians and doctors who have burnout are less likely to feel that they have a responsibility to report impaired colleagues. We also have data from a longitudinal study of residents that if you look at their burnout at 2 time points, the residents who were never burnt out, they actually had the lowest amount of bias toward Black patients. The residents who improved in their level of burnout had a reduction in their level of bias. And the residents who had worsening in their degree of burnout over the course of a year had worsening in their degree of bias toward Black patients. So there is a potential that burnout is also contributing to disparities in care. And there are multiple meta-analysis and systematic reviews that have concluded burnout impacts quality of care in a variety of ways. So our studies have shown relationships between burnout and medical error. Surgeons who have burnout are twice as likely to be involved in medical malpractice litigation suits. The level of burnout in nurses and doctors in an ICU is an independent predictor of patients' mortality. And the level of burnout in nurses is an independent predictor of hospital-associated infections. So those are just a few examples of why people have labeled burnout the missing quality indicator. There's also relationships between burnout and even self-reported work performance, which very closely relates to supervisor-related work performance, and relationships between burnout and career choice regret among our healthcare workers. This is true in nurses, this is true in physician assistants, and also true in practicing physicians. And this relates to healthcare workers reducing their clinical work hours and also leaving their current practice. Here you have data from a longitudinal study we conducted at Mayo Clinic, and as burnout worsened, just by 1 point, the likelihood that that physician was going to reduce their time taking care of patients increased by 43%. And if you sort of extrapolate our data to a national level, this would equate to losing 3 graduating classes of medical students a year because physicians were cutting back on their work hours as a direct result of being burnt out. We also have found that burnout is associated with physicians leaving the practice, not only saying they're going to leave the practice, but actually leaving the practice, with several studies showing that physicians who are burnt out are about twice as likely to leave their practice relative to other physicians, and a group of those not choosing to practice medicine again. And this is very expensive. In an analysis we conducted with Harvard and the University of Singapore, we were able to estimate the attributable cost of physician burnout related to reduction in work hours and turnover. And this is costing the United States $4.6 billion a year. At the level of an organization, it's costing $7,600 per physician per year. So a very expensive phenomenon. And of course, that's only numbers related to physicians who are burnt out and cutting back their work hours or leaving their practice. We also have longitudinal data in the rest of the members of the healthcare team showing the same relationship that burnout predicts healthcare workers reducing their time taking care of patients over the subsequent 2 years. But if the business case doesn't work, you can try the moral imperative. We know that U.S. surgeons and medical students with burnout are more likely to have alcohol use disorders, that physicians and nurses have higher rates of suicidal ideation relative to other U.S. workers. We've shown that burnout is associated with higher odds of suicidal ideation, independent of depression, and even have a longitudinal studies in medical students showing that burnout is an independent predictor of medical students developing thoughts of suicide, even after you control for symptoms of depression. And all of this data is causing many, including Victor Zhao, who's the head of the National Academy of Medicine, Science, Engineering, Daryl Kirch, who at the time was the head of the Association of American Medical College, and Tom Naska, who's the head of the accrediting organization for all residency programs in the United States, to really say that we have an urgent shared professional responsibility to respond and develop solutions. So that's where the consensus study came in. This was a product of the National Academy of Medicine, Engineering, and Science, really pulling together what is all the data around clinician well-being, what are some of the drivers, and importantly, how should we move forward? And it's really clear that the drivers are complex and they're multifactorial. One little tweak in healthcare or one little fix in a team isn't going to all of a sudden solve the problem that we have. What we do need is a system level approach that really figures out how to better balance resources that we have with demands at work. So many of you are familiar with this, resource demand sort of conceptual framework. And resources come from many different places. They're not only staffing levels, but they're social support at work. They're meaning, value, and purpose. It's about leadership at work. And then the demand is not only, how many patients we have to see, but also the inefficiencies in our work, the lack of control, flexibility, and autonomy. One of the things that you may experience yourself as a patient is your clinician being frustrated about the electronic health record. I think of it as a flip phone. It needs to evolve to be, the latest version of the iPhone. Physicians and nurses really rate the usability of the electronic health record very poorly. And how they rate the electronic health record relates to their risk of burnout. And as you sort of improve the electronic health record usability, you see a reduction in burnout. So this is where some of the solution does lie. But there are many reasons why physicians are on average spending 2 hours on the electronic health record for every 1 hour of patient care that they engage in face-to-face. Some of it relates to the electronic health record inefficiencies, but some of it also relates to other things that are going on within the electronic health record, such as patient portal messages or secure messages from patients, which it's a very large volume, and there's often no time on the clinical calendar to help get that work done. In fact, large studies, over 100 million patient encounters across multiple different healthcare systems, have seen that physicians are spending, a substantial amount of time on chart review and documentation, and even putting in orders into the electronic health record. All of this takes time away from important tasks such as, examining the patient, taking a history, making the differential diagnosis, and figuring out the plan of care. But there are also things within the culture of medicine that are contributing to increased work stress and are contributing to burnout in healthcare workers. Although we would ideally like to have great dynamic interprofessional teams that work together really well, that doesn't always happen. There have been studies about mistreatment, belittlement, harassment. This one in the New England Journal of Medicine recently, about residents in surgery experiencing gender discrimination, racial discrimination, sexual harassment, and having these sorts of experiences increase the odds of burnout as well as suicidal ideation. And unfortunately, the most frequent offender were attending surgeons. So this is definitely an issue that we continue to need to work on within the House of Medicine. We have also shown in our large national studies of U.S. residents that female residents are more likely to experience negative interpersonal experiences at work relative to male physicians. And indeed, having these negative interpersonal experiences are independently related to the residents developing burnout a year later. Now, in this particular study, being a woman was also an independent risk factor for having burnout. However, that was really because they were having more negative interpersonal experiences. So if you looked at sort of the impact of having a negative interpersonal experience at work on a male resident versus a female resident, the impact on them was the same. But because women were having so many more of these negative interpersonal experiences, that's why they remained at higher risk for burnout. So, given this, what's the path forward? Because I think that's really the most important part of the conversation today. We've done a lot of research on prevalence. We've done a lot of research to build the so what case. We have some evidence around kind of the now what, which is really the path forward. What are some solutions? One of the big components when thinking about how to design well-being system, which we highlight in the National Academy of Medicine book that you can download for free, or you can read the Cliff Notes, is it takes commitment. It takes leadership, infrastructure, resources, accountability, and culture. In the culture piece, it's really about, aligning decisions, policies, mandates, resource allocation with the values of the workforce. If you take the mission statement on the wall and you really make sure that guides all of the decision makings within an organization, that helps to ensure that this alignment is happening, and then that can drive meaning, value, and purpose for healthcare workers. We also need to redesign how we deliver care to patients so that not only do we improve quality and safety and reduce costs, but importantly, we also meet the needs of the members of the healthcare team. We need to target system factors that we know are contributing to high work stress so that we get a better balance between job demand and job resources. And then we need to continually engage in measurement, like many of you are familiar with, to become a learning organization and continually improve. So the National Academy of Medicine report talks about human-centered design processes, right? And that starts with measuring and monitoring using validated tools that ideally have national benchmarks, and that also include getting insights into what are some of the work system factors, then using that data to guide system-oriented efforts, taking the data to the work units where there is a lot of burnout and co-designing solutions, and then, of course, measuring outcomes and continually improving. So how do you sort of measure well-being of healthcare workers? In the National Academy of Medicine toolbox, we put together several tools that are out there. There are obviously others, but we went through what are some of the pros and cons of the different inventories that are currently commonly used in healthcare settings. Some of them have national benchmarks and some of them don't. But what we can do, and this is an example using the Wellbeing Index at an organizational level, is if an organization is using the Wellbeing Index, they can get, immediate reports about how their workers are doing, how they're doing in different job categories, how they're doing in different specialties. And this is an example of physician specialty. Oops, sorry, I just went forward by accident. So if the score is higher, for example, in anesthesia within an organization relative to what it is nationally, it points toward that there may be some local problems that are driving high work stress that can be dealt with by work unit leaders in collaboration with the anesthesiologist and the healthcare teams in those units. On the other hand, if the level of distress in the work unit is much less than national norms, so this example here would be psychiatry, that what's driving stress in that work unit is probably more related to external factors. And although everybody certainly deserves attention to improve the work and learning environment, given limited resources, it makes sense to target work units where the level of distress is higher than national benchmark data. Using that data, organizations can then move forward with collaborative action planning, which is really about, listening to the boots on the ground, the anesthesiologist and the care teams, for example, to really seek to understand what are the local drivers, and then to collaboratively come up with action plans within the sphere of influence of the local work unit and engage in continuous cycle of measurement. When we have done this sort of process at Mayo Clinic, about half of the work units improved. So it's a difficult thing because there are so many different drivers that are contributing to high levels of work stress. And the more engagement you have between the employees and between management, the greater the gains you see in well-being. Within healthcare, we have many different targets to work on optimizing. These are just a few that you see here on the screen, but it can be very local, as well as factors outside the immediate control of a health or care organization that is driving high levels of work stress. I mentioned the electronic health record earlier, and the experience of the healthcare workers is really influenced by multiple factors. So it's certainly influenced by the US healthcare system. It's influenced by the vendor of electronic health records, and it's also influenced by the organization in terms of different decisions that are made. Another area where there can be intervention to improve well-being within the healthcare teams is to work on leadership capabilities. So these are 3 cross-sectional studies where physicians, other healthcare workers, as well as residents rate the capability of their immediate physician supervisor or their immediate respected supervisor. And what we found is that for every 1 point decrease in leadership score, there's a pretty substantial decrease in burnout, as well as increase in satisfaction with the organization. And we've subsequently done a longitudinal study, which has shown that as you increase the leadership score, the subsequent risk of burnout and the satisfaction with the organization is influenced by that 2 years later. So there does seem to be a suggestion there that if we work on local leadership skills, we'll also be able to reduce burnout and improve satisfaction of healthcare workers. And these aren't like some sort of super difficult leadership skills. These are, skills like holding career development conversation, inspiring, empowering, seeking input, listening to ideas, being respectful, keeping people informed. And, the suggestion here is that relatively small improvements in behavior could potentially have large impact on the level of burnout within a healthcare work unit. Beyond that, there's decisions that can be made with the level of hiring, career development, and assignment of tasks that can also relate to the risk of burnout. Although, as a physician, it's very meaningful to take care of patients. The reality is that for many people, there are different aspects of their job that they enjoy more or that they find more meaningful. Now, it might be certain types of patients, it might be certain types of care settings, but it could also be, educating the next generation of physicians or educating the next generation of physician assistants, et cetera. And if a physician in the study can spend just one day a week, so 20% of their work effort, engaged in the activity they personally find most meaningful, they are less likely to have burnout relative to other healthcare workers who aren't able to do so. So how good your career fit is, depends on if you took and were hired for the right job, how much you're able to do that job shaping or job crafting once you get there, and how well your interest in what you find meaningful really kind of aligns with your capabilities. But there is some signal here that career fit makes a big difference. The other big challenge we have in medicine relates to satisfaction with work-life integration. I've given up on balance a long time ago. Now I'm into, let's just try to integrate it, make it all work. And U.S. physicians and nurses are less satisfied with work-life integration relative to other U.S. workers. Some of this relates to having work-home conflict, which is very common in physicians. And it's very much associated with their risk of burnout, as well as with their intent to reduce work hours and leave their current practice. So building ways to have a little bit more autonomy, a little bit more control, a little bit more flexibility at work are strategies that should also help reduce burnout in healthcare workers. Now, we have found, with respect to flexibility, we found that if physicians have burnout, if they reduce their work hours, they get their severity of burnout decreases. So this is emotional exhaustion, which is one domain of burnout, depersonalization, which is another domain of burnout. It's not a panacea. It doesn't necessarily work for everybody, but it is sort of a self-preservation strategy that can help. So organizations should, allow some flexibility for healthcare workers who really are experiencing burnout to actually reduce their work hours as a way for them to sort of recuperate and get back in the game. Now, obviously, that does have negative impact financially as well as access to care, but we would certainly rather have that individual step back and get better and then come back than to have them leave the organization or have adverse individual or professional consequences. I also alluded to, if you remember in the very beginning, the relationship between social support and risk of PTSD, of other forms of psychological distress related to COVID. And there are multiple studies that you are aware of, I'm sure, about how social support can buffer against stress. And we have done 2 randomized control studies that have really tried to build more social support among physicians. So the first one was a 19-week randomized control study where physicians were allocated to small groups, and each group had a trained facilitator. It was on company time. And they really tried to talk about, what are strategies for improving work-life integration? What are strategies for dealing with medical error? What are, problem-solving strategies, sharing tips and tools? And what we found in this study is that burnout decreased in the intervention arm relative to the control arm, with results being sustained for 12 months. So, in our usual style, we go up to the leaders and we say, we have a great solution. Our approach to reducing burnout in our colleagues is we want to be able to have these small facilitated small groups on company time. Well, you can kind of imagine how well that went, just because of the cost associated with that. So in version 2.0, Dr. West, my colleague at Mayo Clinic, ran another version of the Compass groups where physicians essentially self-formed groups. They met on their own time, but we gave them a topic to talk about and we reimbursed for their meal. And what we found was that even with these sorts of groups, which required very little organizational infrastructure, that burnout, depression, intent to leave the current job decreased in the intervention arm relative to control. And we now have over 1,500 physicians and scientists across the Mayo Clinic who are engaging in these Compass groups. I've also run 2 randomized controlled studies looking at the impact of professional external coaching on the well-being of physicians. So this is the one that was published in JAMA Internal Medicine in 2019. And you see here that physicians who had the coaching relative to the control group had substantial reduction in their burnout, improvement in their quality of life, and also improvement in their measured resilience. Now, speaking of resilience, there's a lot of talk, about mindfulness, and many studies have shown that mindfulness can result in improvement in well-being of healthcare workers, of other individuals, and that even these gains can be sustained post-intervention. And it's an important strategy when people volunteer for it. So all the studies have volunteer bias, which is important for us to keep in mind. A fact I didn't keep in mind when I designed a study where we had a mindfulness course that was integrated and required into the first year medical student curriculum. And what we found is you actually can't require people to be mindful. In fact, there were no measurable improvements in well-being or in empathy of the students. So I think it needs to be on the menu, but it can't be the only thing offered, and it certainly shouldn't be required. And we also have to be careful around our language. Although it is a shared responsibility to reduce work stress for the individual healthcare worker, the work unit, the organization, and sort of the bigger house of medicine and the healthcare system we have in the United States, we do have to be careful when we talk about individual strategies. It can backfire amongst healthcare workers, and rightfully so, because the stressors are coming from the system, not because they have some sort of innate, or we have some sort of innate weakness. And this study here published recently in JAMA Network Open, first author Colin West again, you see here that in a large national sample of physicians, they had higher levels of resiliency relative to other US population that persisted on multivariate analysis. We did, of course, see a relationship between resilience and burnout, but importantly, about 29% of the physicians who had the highest possible resiliency score, still had burnout. So just here toward the end of my formal remarks, one thing that's really important, particularly in today's environment where we see substantial distress in healthcare workers, is we need to figure out how to better facilitate help seeking. And there's obviously several steps to help seeking. You have to figure out you need help, you have to be willing to seek help, and then you have to be able to seek help. And of course, the third thing is very difficult for everybody in the United States, given the shortage of healthcare grounded in insurance issues. But I just want to talk first about self-assessment. So even though doctors diagnose all day long, other people, we're actually not very good at diagnosing ourselves. So this is a national study of physicians. We asked them simply how would they rate their well-being relative to other US workers within their specialty group. And 89% of them thought their well-being was at or above average. So being from Minnesota, I call this the Lake Wobegon effect, right? But, it's remarkable that even, 70% of those who really had scores in the bottom third, still thought their well-being was at or above average. So self-assessment is really tricky, which is why we developed the well-being index. There's an app for it. People can do it on any computer for the individual. It's free. There's different versions depending on what type of healthcare worker you are, because we do a lot of validation work. The healthcare workers who use it find the feedback helpful regardless of their level of distress, and many intend to make behavioral changes as a result of the feedback. Individuals can sort of track their well-being over time, because the idea there is to make micro corrections rather than to all of a sudden being really down and then having to make, do major things to get back on track. For organizations that have a subscription, they can access these anonymous de-identified reports like I talked about earlier, where they can look at the scores according to different parameters like where in the hospital, specialty setting, nurses, doctors, gender, race, ethnicity, etc. The tool also allows healthcare workers to anonymously put in ideas for leadership about how to improve their work environment. But even if healthcare workers can recognize they're in distress, unfortunately, many of them are not willing to seek care. So 4 out of 10 physicians in a study we recently did who had suicidal ideation indicated that they would not seek professional help. Similarly, in another study I ran, 1 out of 4 nurses who were experiencing suicidal ideation so that they would not seek help. And in the figure there, you see that medical students and residents were less likely to say that they would definitely seek help for a serious emotional problem relative to the US population. And part of the reason why that happens, why 40% of physicians are reluctant to seek mental health care, is because of the medical license application questions that they are asked by their state. So this is a study from 2016 where I looked at every initial and renewal medical license application question to see what are the questions around emotional mental health. And you can see all the states in red, neither their initial nor the review nor the renewal medical application questionnaire had questions about mental health that were appropriate. Okay, so who defines what questions are appropriate? Well, the American Medical Association, the American Psychiatric Association, and even the Federation of State Medical Board, has said that you shouldn't ask about if people have, a current or previous diagnosis of mental health. You shouldn't ask if they have had previous impairment. So, this is a continual problem. And when it was looked at again just recently here in 2021 by other investigators, they found that most state medical boards are not following the recommendations from the Federation of State Medical Boards regarding licensure applications. There is one state that is doing extremely well. Now, I do have to report that after great collaborative work with many organizations, we were able to get the question changed regarding previous and current mental health in the state of Minnesota, but we also continue to have work to do in that area. In licensing, medical license board is just one aspect. You could be asked these questions by hospital credentialing boards, by medical malpractice insurers. So it's something that needs ongoing work, as well as consideration for legal protection around personal health information for physicians when they're involved in medical malpractice litigation suits. And then we have a piece to work on with respect to our culture, so that the work and learning environment is supportive and doesn't unintentionally in some way discourage access and care. And that leads to the need for really advocating for regulatory reform, for collaborating with health information technology system developers to really make sure that the tools we have are optimizing our ability to deliver care, reducing the cognitive workload of healthcare workers, and overall improving efficiencies and reducing workloads. And as we called out in the National Academy of Medicine report, it would be great to see incentives develop for really the creation of new technologies that can improve quality of care as well as enhance well-being of our workforce. So with that, I'd like to conclude my remark, hoping to leave time for questions. It's really clear that we need action at multiple different levels within the healthcare system, the level of the individual, level of the work unit, level of a organization or employer, level at these sort of external healthcare system factors, so that patients can really receive compassionate care from committed, competent, professional physicians, as well as other healthcare workers. So I'm going to stop sharing at that point, and thank you very much for inviting me today and for your attention.
All right. Well, Dr. Dyrbye, thank you so much for a fantastic presentation. I want to remind our audience to go ahead and type in some questions that you may have in the Q&A box, and we will start. One thing I have to say I was really impressed with is just this discussion about kind of this holistic approach to prevention. I think you touched upon everything from all levels of intervention, and ending with advocacy. There is a question here, are there any short-term solutions? So certainly at this stage, and you talked certainly about the frontline workers who are probably of most concern, what things can be done, what solutions can be applied, particularly during the pandemic?
Yeah, I think, the short-term solutions needs to really focus on getting people who need help the professional help they need. So, some organizations have made, for example, change to their medical plan, to ensure that it's affordable to seek mental health care, either, waiving deductibles, waiving copays, just trying to figure out, how to remove some of those barriers for people to seek care. Those are very immediate things that organization and employers, can do to get the people who really are in a lot of distress help. So that clearly needs to be sort of the first step, is to help the people who really are suffering recover from that. And that also, organizations can also immediately put more flexibility and leeway into, having healthcare workers reduce their work hours, having, people go on temporary leave so they can recover from the distress. And then the third thing I would say is there are ways to build social support within an organization that don't necessarily cost a lot of money or take a lot of time to implement. So figuring out particularly, how can you safely sort of bring people together in person or virtually to start to kind of rebuild those social connections and those social support at work.
Thank you. Speaking of which, there's a related question about the work hours. And if one, an organization were to allow the reduction of work hours, would the providers their compensation be reduced? Or did an organization, would they absorb the cost? Like, what strategies have you seen? And how do we deal with these concerns, the economic concerns and impacts?
Yeah, that is a real concern. Ideally, workers should have a reasonable workload during their scheduled work hours, right? So, and what I unfortunately see all too many in colleagues who are, 0.8 or reduce their work hours is they're just getting paid less for the same amount of work. We're not necessarily very good at adjusting the workload to fit the time that people are actually allocated to be working. So that is one thing that we definitely need to fix. Otherwise, from a very sort of individual, personal perspective, that's exactly what happens. If you reduce your work hours, you're going to reduce your pay. And I think that this is a place of, that often gets a little contentious. But many physicians are very highly compensated, and they can make decisions, right, about their personal expenses to allow them to work fewer hours. Now, ultimately, what we want to do is improve the work environment, right? So that, people can work the allocated work hours and thrive. And the burden to sort of reduce work stress shouldn't be on the individual shoulder, right? It really should be on the shoulders of the organization to, improve the work efficiency, improve the task allocation, improve leadership's capabilities, and to take those sorts of steps. But an immediate short-term relief valve option, for an individual would be to reduce the work hours as long as they could, manage the financial ramifications of that.
How do you see this working, say, for other types of healthcare professions, such as the nursing, where there might be some issues around economics that are just a little bit more stressful for that group?
Yeah. So what we're starting to look at now is what we call talent movement. Mm-hmm. So that's pretty tough for doctors to do because of our specialty training. It's hard for us to move jobs within an organization. Nurses, on the other hand, have more of an ability to move from one work unit to another to where they at least perceive the grass is greener. Whether it is or not, it's always kind of be a little bit hard to tell, right? So that is one mechanism for nurses as well as physician assistants, nurse practitioners, to not go the way of reducing the work hours, which might have bigger financial implications, but rather to look to transition. For example, those who are working in emergency medicine in the emergency department, critical job, but it appears to be more stressful than other areas. Yeah. There are differences by inpatient versus outpatient settings. So an individual, could look at that as an individual strategy, but again, it would be great to get those nurses in emergency medicine working alongside the rest of the practice innovators to figure out how do we really improve the work environment so that all of us can stay here and do the very important work of taking care of acute patients.
In that co-creation and co-management strategy, I think that was a really important theme of your presentation. And you certainly talked about how you were able to implement that in Mayo with the Listen, Act. Is it Repeat? Mm-hmm. Is that the Listen, Act, Repeat? So how can we employ that strategy, particularly for under or marginalized groups. We talked about, females, physicians experiencing more negative interpersonal experiences. And certainly we're thinking about BIPOC physicians or clinicians. How can we integrate them? And have you seen some successful approaches in sort of this co-creation, co-facilitation process?
Yeah, I think that this is where the drive to have chief wellbeing officers is partly coming. So you need to have sort of someone who's accountable and resource to ensure that local work units, divisions and departments are working on improving the work environment, are doing the factors that are within their sphere of control, and then, sending up to leaders the things that aren't in their sphere of control, and to have this continuous learning and improvement cycle. And the individuals who are doing this sort of work to improve the practice, improve the work and learning environment, they need to have tools to not only listen to the loudest individual, but also to be able to really seek ideas and opinions and participation from marginalized communities. There are a variety of different ways to do that. Surveys can provide a little bit more anonymity. People might feel a little bit safer to make their suggestions. There's a mechanism that I often use called liberating structures, which is kind of different ways of doing group discussions that really enable the voices of the introverts and the marginalized healthcare workers to be heard. For example, you might have two people talk about what's your idea for how to improve the work environment. These two people then pick one idea. They then meet with the other two people, so now you have 4 people who then came together and put forward one idea. And then you have 8 people who came forward to put one idea. So that's just one example of how you can get participation from marginalized communities or from the introvert to engage in that sort of idea generation, what might be some of the solutions. And then it's obviously up to the leaders to pick an action team that's representative, of the community of workers, so that everybody's engaged. We don't want to put forward solutions that work for physicians that then make life worse for nurses or nurses assistants or, the desk staff. It really does have to be an interprofessional, community-based team approach to improving the work and learning environment.
Thank you. Thank you. So we've got a lot of questions in the Q&A too that are a little bit more digging into the detail of some of the work that you presented. So I'm just going to go through them. And a comment, actually, this is a very relevant comment since you just talked about this, a well-being officer. So Tamara, thank you for this comment. This is the work she's currently doing in the VA Health Administration as well, piloting the role of chief well-being officers and using Listen, Sort, Empower, Act as an intervention tool. So that's really wonderful to hear that it's being used in practice. So a couple of, other questions from Letitia. Do you know of any studies or interventions that have focused specifically on burnout among non-clinician health workers, such as medical laboratory workers whose workload has exponentially increased during the pandemic?
Yeah, so when we did the National Academy of Medicine consensus study, it was a 2-year process. It involved reading over 4,000 articles. And it was actually very disappointing how little research there had been done outside of physicians and nurses. We have studies in medical students, we have studies in residents. We have very little in other members of the healthcare team. So this is really an area where we need people to, start to engage in replication research or innovation research, so that we have a better understanding of, how do we help lab technicians? What are their drivers? Because they're likely different. And then importantly, to build the case for the so what, so we can move on to the now what, which is really that intervention.
Yeah, and hopefully the strategies that are being employed here would be applicable, could be translated to these, to other non-clinicians. Another question, are future physicians learning about physician work burnout in their coursework?
They're certainly experiencing it. So what I didn't talk about today is all the literature and the research we've done on medical students and residents. So medical students come into medical school with better mental health profiles than any other college graduate. But unfortunately, once they're sort of under our collective wing in academic medicine, that story changes. So they get more burnt out, they get more depression relative to similarly aged US college graduates. And that's also true in residency. Residents have more burnout, they have more depression relative to other US college graduates of their age. So they experience it very often early, unfortunately, and it comes from the learning environment, it comes from the work environment, and there are initiatives around improving that. It's also this idea of shared responsibility, right? So many medical schools are also trying to teach the importance of self-calibration and self-assessment, are trying to teach what are some positive coping mechanisms. The students are very bright. They've gone through a very challenging, university-based education. They know a lot about how to study well and how to deal with stress, but everybody can always get a little bit better. So again, it's that challenge between reminding them of the individual strategies and then, 80% of that effort really on improving their work and learning environment, which is where it's coming from in the beginning.
Great. Here's something really interesting about the work environment and organizational structure. When you talk about limiting time per patient, do physicians actually have control over this? So David Abrams says, I've watched my friend who has had to close their small practice and join a larger health organization, lose control over much of what they do.
Right. That's a big challenge. It's been a big shift in medicine, from a small independently owned private practice to being an employed physician, part of a larger healthcare system. And as a result of that, physicians have often gained some financial stability, have help with information technology like the electronic health record and all the mandatory reporting that's required within states and et cetera. So it's been helpful in many ways, but there's always a downside to everything, and a lot of control, autonomy, and flexibility has been lost. And that's a big challenge. Things like, is it a 20-minute appointment slot or a 30 or a 45-minute appointment slot is generally outside the control, of the physician. So, it is a big challenge, and it's also a big acculturation process, right? How do you remain a professional and not a cog in the wheel? How do you sort of feel about it? How do you really optimize meaning, value, and purpose so that you can continue to thrive?
Yeah. It's interesting. You talk about the medical electronic health records. Now, obviously, again, the pros and cons of this. And here one question is, when looking at the time in the electronic health record, how does this compare with older paper charting time requirements? It strikes me that some of this time is actually well spent, obviously, but, and what we gain is patient communication is much more efficient. And yet some of the research that you showed did show, this being a source of burnout for physicians. So how do you kind of manage that sort of potential conflict here?
Yes, there are some great things about the electronic health records. There's no doubt. I'm actually old enough to know about the paper charts. That's what we used when I was a resident. That's what I used when I started in private practice. But it is different. So it can be fast to put things into the electronic health record, or it can be slow. It can feel like checkbox medicine, where you're checking like information about, checking little boxes instead of like writing a story. You can just imagine the difference in pace between dictating something and having to type something or having to check little boxes. And the note's only one piece of it. The other piece is about order entry. So in the, before electronic health record, we would just have a sheet of paper and we'd check, okay, they need these tests, and you give it to the desk. It's very quick. Now, we have to put in, well, they need a blood test because of this reason. They need this particular chemistry test because of this reason. They need this x-ray because of this reason. And the x-ray form has 20 different fields you have to fill out. So it's much slower. The other good and bad thing about the electronic health record, as I alluded to earlier, has to do with the patient portal. It's a great tool for communicating with patients, and it's a great bidirectional tool. There are really great ways you can figure out, well, what were your test results instead of coming in and missing work, right? But on the other hand, a primary care physician can have between 15 to 30 messages from patients at the end of the day. And that primary care physician did not have a shortened face-to-face clinical calendar. Mm-hmm. So somehow that primary care physician needs to answer those 15 to 30, patient care portal messages in a meaningful, thoughtful, accurate way. And that's part of adding the stress, right? So the system needs to be redesigned so that some of those portal messages maybe can be answered by other members of the healthcare team, whether it's a pharmacist or a nurse or a secretary. So triage needs to be improved, and then time needs to be allocated, on the clinical calendar to engage in this very important but non-face-to-face work.
All right. So we've got kind of a really interesting question here. I just had a leadership member in my office while watching this presentation, and I was discussing the impact of leadership on burnout. You mentioned helpful leadership skills. I think this would be nice to share again the essential skills for leaders to reduce burnout. And I'd say any of us who are leaders or have a leadership role, they are very much applicable across the board.
Yeah, they are really, really important skills. So this really comes out of our work where, when I was a physician at Mayo Clinic, I would regularly rate my immediate physician supervisor across the dimensions that I talked about. And that score is an independent predictor of my burnout and my satisfaction. So the behaviors that I talked about were holding career development conversations, which probably relates to career fit, right? Like, what do you find most meaningful? How much of your time are you spent doing that? What do you want to do next? Inspiring people, empowering them to be able to really do their job, make independent decisions. That's kind of an autonomy issue, right? Seeking their input, listening to their ideas is about that sort of collaborative action planning. Kind of goes back to the nothing about me without me. Treating people with respect, that seems to be a no-brainer, but also keeping people informed. There's lots of changes that are going on in a work environment, and people can only take so many emails, right? Or can only go to so many meetings. So how can you, in a pragmatic way, figure out how really to keep your staff informed? And then just encouraging people that you work with to develop their talents and skills. So those were the things that we measure across the Mayo Clinic leadership score.
Yeah, I think they're just important and incredible skills that should be applied to all leaders in all employment or organizations. All right. Well, we've got one last question, and this one is really interesting. What do you think the impact would be if we were really able to ramp up the distinction between mental health and mental ill? That is health and mental illness.
Yeah. I really like that. So sort of the World Health Organization says to be well is more than the absence of disease, right? And I think that is incredibly important. The goal for healthcare workers and for all workers really shouldn't be just the absence of burnout, right? Or just the absence of depression. Ideally, we want to get to a spot where we're really thriving, where we have quality of life. And I think that's an important goal. In terms of, the conversation, switching that conversation is very important. How do we really get to mental health, physical health, overall well-being, rather than always having to focus on the negative? And I think part of it also is we need more research around how can we amplify the things that are working. So what makes people mentally healthy, or we know a lot about what makes people physically healthy, right? But really figuring out from an occupational perspective, how can we do more of what is working while we work on repairing the things that aren't working so well?
Well, Dr. Dyrbye, we really want to thank you so much for your time today. I think you covered how mental health crisis among healthcare workers actually existed before the pandemic. It certainly has been exacerbated, but continues. So there's a lot that we can reflect on, that we've learned on today. And again, we thank you for all the insight into the incredible work that you do and that you've really inspired others to do.